Afternoon all, and at the outset I'd like to thank AIOS for this amazing array of international speakers. I am going to talk to you on FACO in compromised Rhexis. Nothing financial here. Uh, One of the basic prerequisites of a safe FACO is an intact Rhexis. And most of the time, the Rhexis is indeed intact. However, from 0.79 to 5.55% of the cases, there may be a Rhexis compromise. And what do we do if we have a Rhexis runaway? In fact, there was a publication from Moorfields at the American Journal in 2015, where the incidence of compromised Rhexis was 1.5%, and in the same series, PC rent was noticed in 1.65% of the cases. So when we are confronted with a compromised Rhexis scenario, how do we proceed? The decisions that need to be taken are: do we continue with phacoemulsification or convert to a non-phaco, a safer non-phaco technique like SICS or extracapsular cataract extraction? Now, if you decide to go ahead with phacoemulsification, do you use the same technique that you have been using endocapsular, or do you perform phacoemulsification at a different level altogether? And finally, if the phaco goes on smoothly, the intraocular lens, would you be opting for a three-piece hydrophobic acrylic lens or a single-piece lens? And what if it was a patient who desired a toric lens or a multifocal lens? So these are the issues which I'm going to discuss in my presentation. Timing of the tear is very important, and I'm going to talk to you about the primary Rhexis tear in manual phacoemulsification, where you get a tear during the Rhexis construction. I have also encountered the same problem as a secondary Rhexis tear, in situations where the Rhexis was small and the visibility was an issue, and for some reason or the other, the Rhexis margin got damaged, got injured either by the chopper or by maybe the phaco handpiece or by the phaco tip. We also need to look into the risk factors which predispose to these complications, so that we can give a better counseling to the patient and can have a better surgical armamentarium plan for the complex situation. I have last 27 years of my phaco career, more than 10-15 cases, and I'm going to show you one video here. This was an intumescent cataract with a very high intralenticular pressure. Anterior capsule was stained with trypan blue dye, and I'm using a soft shell technique. Plan is to make a two-stage Rhexis, and it goes on pretty well to start with. But at one point, I realized that there is an edge which tends to run to the periphery. So here you got to be careful. So I again inject a cohesive OVD peripheral to where the Rhexis has a tendency to run off to. Since I didn't have much purchase on the Rhexis with the cystitome, I use a nutrator forceps. But then again, there is little control over how the Rhexis progresses. And though I injected Hilon GV on the peripheral aspect, still there is a Rhexis runaway that happened. Now, my presentation today is not on what went wrong with the Rhexis and what could have been done, but rather how do we go ahead henceforth? How to manage the subsequent steps of cataract surgery? So I would like to have about a 5 to 5.5 millimeter opening of the central anterior capsule. So I use my micro-Rhexis scissors and forceps from the main incision and from the side incision, from the side ports, to give me a very good access to the underlying nucleus, which is pretty much hard. There are some surgeons who believe in giving an opposite relaxing cut to the Rhexis margin. I haven't done it, but I think I reckon this is one of the options. Hydro steps should never be performed. I never perform hydrodissection in intumescent cataracts because there are no adhesions and there is no need to perform a cortical cleaving hydrodissection. In this situation, if you try to do that, there is always a possibility of the Rhexis tear extending to the periphery. Now, we have had publication, Dr. Rohit Om Prakash, about capsular flap motility sign. So in this case, both the edges of the Rhexis tear are everted, which tells me that most probably the Rhexis tear hasn't become a wraparound tear. So I go ahead with phacoemulsification, make a deep beat or trench with a very high phaco power because I don't want the nucleus to be moving around. And then I start chopping a vertical chopping using just the Sinskey heel. While chopping the nucleus, just ensure that the nucleus is elevated a little anteriorly so that the chopping maneuvers do not have any extra force transmitted to the area where the Rhexis was torn. At several points in the surgery, the anterior chamber was topped up with viscoat, a dispersive OVD, because you need to protect the corneal endothelium. I'm performing phaco at a little anterior plane, so this is very important for us to be mindful of the cornea and protect the corneal endothelium, as well as maintain the anterior chamber depth. And again, when you perform the tear, the chopping maneuver, it is always better to avoid the area where the rhexis tend to run to the periphery. And the nucleus rotation has to be done extremely gently. The basic game plan here is the bag is already compromised, and we don't want to create any further damage by inducing additional pressure within the capsular bag. So all the maneuvers go on in a very slow motion. Anterior chamber depth has to be maintained, and though I have edited out injection of the dispersive OVD, that was injected several times. So using this maneuver, the successful phacoemulsification was achieved. The nucleus, if you see, is not a very hard nucleus. It's sort of a brittle nucleus. Maybe that is the reason why I decided to go ahead with phacoemulsification in this case. Adequate cortex removal was performed. And then here, I decided to use a 3-piece hydrophobic IOL in the sulcus. So, though I agree that a single-piece hydrophobic acrylic can also be implanted in the capsular bag, because the unfolding is very slow. But in this particular case, this was my decision. So here, the incision is enlarged to about 3 millimeters in size. We do not want the anterior chamber to become distorted, cornea to be distorted, and anterior chamber to become shallow. And just make sure that the leading haptic clears the area of the rhexis tear. So if you are not careful at this stage, the leading haptic will go through the area where the rhexis is torn. There will be additional stress to the posterior capsule, and there may be a runaround tear. So the leading haptic just scrapes the anterior capsule, goes safely under the iris. It is resting in the sulcus. Trailing haptic is also compressed, and it is not dialed in. It is compressed, and it is kept in this particular location, as you see here. So the lens, intraocular lens, is oriented 90 degrees. That is at right angles to the area where rhexis compromise happened. And secondly, I also obtained an optic capture, the buttonhole, the optic through the residual rhexis margin, though there's a discontinuity. I have done more than 10 such cases of posterior optic capture. The lens is beautifully locked in place. There is always a risk of asymmetric capsular fibrosis happening postoperatively and the lens getting decentered, but such a thing I have not encountered even after a long period of follow-up. Postoperatively, this patient has been followed up for a long period of time. You see the lens extremely well centered. There's hardly any PCO, and these are the rhexis, compromised rhexis flaps, which are running to the periphery, and the patient has been doing extremely well. So friends, what I'd like to tell you is rhexis is paramount for safe phacoemulsification, but in spite of that, we do have rhexis tears happening, and then we need to take a call as to whether we continue with phacoemulsification. It depends upon a number of factors which are listed here. The surgeon experience, perhaps a senior surgeon with number of years behind him would be ready, willing to continue with phacoemulsification compared to a neophyte. The type of cataract is also very important. Are we dealing with a bruniscent cataract with a thick posterior nuclear plate, whether the pupil is small? The location and timing of the tear out is also very important. Now, if I'm doing a case which is extremely hard, almost a very dark brown or a black cataract, the endothelium is not very healthy, anterior chamber is shallow, the patient and the patient's bystanders are a little difficult, I would rather not continue with phacoemulsification, but convert to a manual SICS technique. So when a junior surgeon, a young surgeon who is not not familiar with manual SICS, he encounters a case like that, I think it is a good idea for him to ask for intervention from the senior surgeon in the neighborhood, in the operation theater, or if none is available, then one can put a suture and the patient can be referred out. Patient good results finally will be appreciated by the patient, rather than a poor result because of your unfamiliarity with the subsequent steps of bailing out from phaco to a non-phaco technique. Phaco can still be performed endocapsularly, or if the rhexis is really torn and you feel that capsular bag may not be a very safe place to continue with the manipulations required for phaco, you can elevate it to a more anterior plane, when of course it goes without saying that you have to use a copious amount of dispersive OVD to protect the corneal endothelium. Use of an appropriate intraocular lens. So a three-piece hydrophobic lens in the sulcus with an optic capture definitely is desirable. A single-piece lens, which because it unfolds slowly, it also can be kept. Even if it is a toric lens, it can be kept. However, in multifocal cases, when I've had a Rhexis tear, either I have abandoned using a multifocal lens in these cases, or I've used a three-piece platform multifocal lens in this Rhexis compromised situation. So, friends, in conclusion, a good phaco is possible in Rhexis tear situations. Condition apply, and if you follow all the guidelines, I'm sure postoperative outcome will be extremely good from the patient as well as the surgeon's point of view. Thank you very much for your attention.
Thank you,